and today we're going to talk about tips and tricks for basic rubber dam isolation. Um, Before we get started, I want to make sure that I put out the very clear objectives that I have for today's presentation. First one being, we're going to be able to identify the materials needed for basic rubber dam isolation. We're going to understand the different types of clamps available and when they should be used. We're going to identify the so-called universal clamps. We're going to understand when a blind clamp technique should be used. And we're going to apply a simple and step-by-step protocol to achieve ideal rubber dam isolation. Before we get started, I want to thank our sponsors for their support, for their continued support, and for their support in allowing us to offer free CE credits through this presentation. I want to make sure that I thank everybody at Colteen. They've been very, very supportive in this presentation, and you will see a lot of their clamps, obviously, because that's what we use every day, and you will see them in our presentation. I want to thank Comet and BNR as well for their support to this presentation. And I want to share with you just a little bit of information on what you need to do in order for you to achieve the 1CE credit that we're offering for all US dentists that are following us today. Um, if you go into our webpage, which is romerodentalseminars.com, this is our homepage right here. You will click under webinars, and there's three links that are very important for you to identify there. The first one is the live webinars link. In that live webinars link, you will be able to sign up for future webinars that we're going to have throughout 2020. So please go ahead and visit that site, that link, so that you can sign up for next Saturday's webinar, part 2 of rubber dam isolation, and for other webinars and other topics that we're going to have throughout the year. On the second link, the one that we call the on-demand link, if for whatever reason you were not able to be part of a live webinar, we record these live webinars, we edit them, and then we upload them into our webpage. So you will be able to watch them on demand. You can do that as well if you want to just remind yourself of something that we said through one of the webinars or any aspect of the clinical tips that we share with you. You're always more than welcome to come back and review any webinar that you want through this link. And finally, we just created this brand new link called CE Quizzes. When you go into that link, you will find this web page, this added page, where you're going to find a PDF file that you're going to click on, you're going to download, you're going to answer the 5 questions that you have there. You're going to give us your information, and you're going to email it back to us. All that information is within that form. So if you want to receive the 1CE credit for this presentation today, make sure that you click on that link, answer the questions and get that form back to us. And we will be more than happy to submit these to the Academy of General Dentistry. Okay, so let's get started. Let's first answer this basic question that I think that we all should have, and that I know that everybody's asking themselves. Well, why are we talking about rubber dams? When this is a topic, a very old topic, and we've been using rubber dam for over 100 years, so over 150 years actually. So why are we still talking about rubber dam isolation? And in today's world, I think that there's 2 basic reasons why we should be talking about rubber dam isolation. And the first reason is the most common reason that we use rubber dam isolation in restorative dentistry, and obviously it has to do with a restorative reason. And basically I want to kind of summarize the restorative reason just by sharing with you these 2 photos, these 2 cases right here. On the left-hand side, this is an endo-treated tooth. And once the endodontist completed the root canal, they referred the patient back to me so that I can go ahead and restore that tooth. So what I'm going to do right here, what I'm getting ready to do, is I'm getting ready to bond a post within this canal and then build up a core. So why is this, or what does this have to do with rubber dam isolation? So if we think about this, when we send this patient out to the endodontist, or if you perform your endo treatment yourself, the number one thing that you do when you're performing a root canal treatment is isolate. And the reason why you isolate is because you want to just make sure that that you're free from any contaminants or taking any contaminants within the canal. You want to make sure as an endodontist or as a general dentist that you want to clean and shape the canal walls to an ideal situation, so that you can go ahead and then seal that canal using your gutta percha. You got to make sure that everything that you've done has been done under rubber dam isolation, so that not only you can keep this clean, but you can avoid using or having any of these irrigants, the very, very strong irrigants that we use, fall into our patient's mouth. All right, you protect your patient at the same time that you're trying to achieve a very nice and clean canal. Now, from the restorative side, when I get this patient, I don't do any root canal, so I'm just going to go ahead and restore this tooth. When I get my patients, I want to make sure that I follow the same protocol that my endodontist, works so hard to get this nice and clean canal, that I keep it that way. So rubber dam isolation has a really good point when you're trying to restore a tooth like this, because not only I'm going to go ahead and remove the gutta percha and re-clean that canal prior for me to going through my bonding steps, so I want to protect my patient as well. But most importantly, I don't want to get any contamination, any bacteria within that canal. I want to make sure that I can seal that canal, that I can bond a post to that canal and have a very nice and clean environment. So that's the number one reason why in a case like this, I would go ahead and suggest that you always have rubber dam isolation. Now, if we look at the right hand side of the screen and you look at case number two, there's a totally different situation here. Now I have a tooth that has been partially prepped for an onlay, or for a partial indirect restoration, and I'm getting ready to bond that restoration. And as you can see, this is a second molar, so it's way in the back in the mouth. Not only that, but look at the mesial and distal margins. So they're kind of low, and I want to make sure that I have no crevicular fluid surrounding those areas, so that my bonding procedures can be predictable. I have no bacteria, no bleeding of the gingival tissues in those areas. And if there is any bleeding, all that bleeding is going to be contained correctly through my rubber dam isolation. So at this point, not only I have a good access and a good view of the area that I'm going to be working on, but I have a cleaned operative field, which is so important prior to you bonding your restoration. So these are two really good reasons why in restorative dentistry you would want to have a good isolation in your operative field. But today, there's a second reason and a more important reason, that is COVID-19. So we know today, not not because we want to, but because we have to. If we follow the guidelines, and these are just the guidelines that the American Dental Association has placed out there for dentists to follow when they are confronted with patients that now need to have an aerosol induced treatment done in a clinical setting. And when you look at this algorithm and you look at the right hand side of this chart, these are the additional measures that the American Dental Association is recommending today in order for us to treat patients under the conditions that we have today with COVID-19. And I'm going to read this literally out of the what the American Dental Association has on their webpage. It literally states that the use of dental handpiece with anti-retraction function, four-handed dentistry techniques, high volume saliva ejectors, and a rubber dam when appropriate to decrease possible exposure to infectious agents. And we know today that we have the techniques that will allow us to use rubber dam isolation in the great majority of our restorative cases, if not in all of them. All we have to do is make sure that we understand if when our clamps need some type of modification in order for us to be able to isolate. Select the correct clamp, select the correct technique, and follow the appropriate steps so that we can achieve ideal rubber dam isolation in more complex situations. So the advantages of using a rubber dam in today's clinical environment are: number one, minimize the aerosolized particles produced during patient care, and number two, help to keep our team members safe when providing emergency and elective treatment. So these are the reasons why we are coming back to the table, and we want to make sure that we review rubber dam isolation techniques. And obviously, I know, and we all know that today we have either basic or advanced techniques, but we're going to start with the basics because these basic principles are going to be used in every single case, regardless of any modified clamps that you were to use for any specific clinical situations. So I'm going to start out talking a little bit about the material selection, because this is again very important. And the reason why I feel that is important is because there's a lot of options that we have out there in the market when it comes to clamps. But basically, before we go ahead and choose what type of clamp design we want to use for a particular clinical case, we have to have the right equipment in order for us to be able to deliver or perform ideal rubber dam isolation. And that is, that relates to having a good dental dam perforator, having a dental frame that works properly, having a clamp forceps as well to go to be able to take the clamps directly into the patient's mouth, have some aid, some additional materials that can help you achieve or gain a good isolation, which is using a floss, a dental floss, a unwaxed dental floss, and using something like a wedget to help you secure your rubber dam in place. And I'm gonna share with you every single one of these materials, how you use them and how you select them. But the number one thing that you want to do is select the type of rubber dam. And again, what I'm trying to do today is just share with you my experience. I've been using a rubber dam for over 20 years in my clinical practice, and I use it, I would say 95% of the times. I want now try to increase that to 100% of the times if I can, in every clinical situation. And I know that we have the materials and the techniques to be able to do that. So the basic thing that you have to know about rubber dams is that there's two sizes normally available in the market. You have the 5x5 and the 6x6 size rubber dams. Now, my recommendation is always go to the 6x6 for your adult patients. The 5x5 rubber dams, size of rubber dams, I only have them if I have any peds patient. I rarely see any kids. So in my practice, the 6x6 is the standard rubber dam that I have available for me to use clinically. Now you have two options. You have the non-latex option and you have the latex option. And we all know because of a latex allergy, we normally are going to go for the non-latex option. I do have some latex rubber dams because I like using, in some cases, I need to use more of a thicker rubber dam, a heavy rubber dam, and normally those only come in latex version. So I don't use them regularly, but I do have them available just in case I would need them for a specific case. And I'll share with you today a case so that you can see when it's indicated and why do I decide to use this. But again, normally I go for the non-latex rubber dam, and I use the medium size, which is it's not thin, it's not heavy. So it gives you, it's easier for you to handle. And again, we're trying to make this simple. We're trying to make it easy for us. So I would say 95% of the times, I'm going to go with the medium 6x6 rubber dam. Today, we have the option for the Flexi dam that Colteen has available for us in the market. It's not a rubber dam that I use frequently, to be honest, but one of the things that I do like about the non-latex or the Flexi dam is that it has these, it's non-slippery at all because it has these little beads on it, or just kind of like irregular surface that would allow you to handle it very nice and well in your patients. But again, this is all about what works best in your hands and what you are used to using. I'm very used to using the non-latex medium, just the regular non-latex medium version of Colteen's rubber dam. So again, I'm going to give you here an example of a non-latex medium blue 6x6 rubber dam for this particular case. And what are the properties that I like about this type of rubber dam and why do I use it so much when it comes to my clinical dentistry? The number one reason is because even though it's a medium and it's not a heavy dam, you get really good retraction with this type of rubber dam. You get excellent contrast. The color of the rubber dam is ideal for you to have that good contrast that you need so that you have better visibility to your working area. Perforations don't need to be that precise because of the size of the rubber dam. And that's another reason why I like choosing 6x6, because if your perforations are not in the perfect spot, the rubber dam, your rubber dam isolation will still be safe. You really have to be way off in order for the rubber dam not to be good for you to use. So if the perforations are not in the perfect place, you will still be able, if they're close enough, you will still be able to use your rubber dam without any problems. And the most important aspect is that is a medium rubber dam is very easy to stretch. And that's one of the things, one of the complications that we normally have, and that I hear from colleagues saying that, they have difficulty when they're trying to stretch the septums between each of the perforations through the teeth. So with the medium rubber dam, you're not going to have so much difficulty to do that. On the other hand, this is a really good example of a heavy latex black 5x5 rubber dam. made by Coltine. And the reason why I chose this rubber dam specifically for this case is because you can see that this is a second molar. I had a lot of tissue distal to the second molar, and I needed a heavy rubber dam to invert and retract or push away the tissue out of my operative field. So for these particular reasons, I chose a heavy rubber dam. Now, what are the benefits of a heavy rubber dam? Well, the number one, you get maximum retraction. This is the reason why they're heavy. This is going to push any tissue away. So if you have any subgingival preparations, if you have any deep boxes, and you're having issues with the medium rubber dam, maybe if just by changing or switching to a heavy rubber dam, you're going to be able to get rid of those complications. It has excellent contrast because it's very, very dark rubber dam. The perforations need to be precise when you're using a 5x5 rubber dam. Now they do have the heavy latex rubber dam on a 6x6 size. In this particular case, I chose a 5x5. And again, one of the downsides to that particular size when you're using it in an adult patient is that your perforations need to be precise in order for this to work out into the rubber dam to protect and isolate in a precise way. And the other difficulty that you may find with this type of rubber dam is the difficulty to stretch the rubber dam or the perforations, the septums between the perforations through each teeth. And the reason for that is because of the thickness of the rubber dam. So one tip that I can give you there is I normally use shaving cream, just the old type of shaving cream, the white foam that is soluble in water. I just put a little bit of shaving cream around the holes, and that will allow the rubber dam to, it'll make it a little bit easier for the rubber dam to go through each of the teeth. So that's just one quick tip that you can use. You don't need to use any Vaseline or anything like that that may interfere later with other procedures that you're going to be doing. So that's the reason why I choose to use shaving cream for that specific aspect. Now, when it comes to clamp options, and this is one of the questions that I get all the time because there are so many clamps out there, and I really want to make this simple. And again, I think I have a lot of experience when it comes to rubber dam isolation because I've been teaching how to do it and I've been using it frequently for many, many years. So I'm going to share with you my expertise and my experience with the clamps and how I have made a very simple selection or very, simple way of selecting my clamps when it comes to rubber dam isolation. So the first thing that I want you to know is that clamps come, you can classify clamps in many ways. One of the ways that companies use to classify the clamps is, by calling them either winged or wingless clamps. For hygienic, specifically for that specific brand, you will see that when hygienic uses a W, before the number that they want to use to size their clamps. If they use the W would mean that the clamp is wingless. So when you have a W, let's say W2 or W3 clamp, you know that because you have that W right before the number, that clamp does not have wings. And those are the clamps that I recommend and that I prefer for operative dentistry. On the right-hand side of my screen, you can see a 12A clamp, which is a beautiful clamp. I like it a lot because of all these, the different, when you look at the beaks, it has multiple contact points for the beaks. So it allows for, multiple uses depending on the clinical situation of the abutment tooth. But one of the downsides to this specific design here, the winged 12A, because they make a non-winged 12A or a wingless 12A, is that you have these wings and this buccal and lingual wings. And these wings obviously are going to occupy more space. So, for that reason, I rather use a smaller clamp without wings so that I have more room for other instruments or other materials that I may need to use, like, either sectional matrices or regular Toffelmeyer bands. You want less things bothering these other aids that you may be using for operative dentistry because you want them to fully seat. And by you having a larger structure, sometimes that can complicate fully seating of either your Toffelmeyer bands or your sectional matrices, or even being able to include a wedge in your operative procedures. And we all know that we need them when we're doing operative dentistry. So keep that in mind. And that's the reason why you have to choose between a wing clamp that is commonly used for endodontic procedures. And I think that for endo, they're a great choice. But definitely for operative dentistry, I would highly recommend you choosing a wingless clamp, like the one that I want to share with you right now. Now, one of the benefits of the winged clamp is that these wings, the reason why they have wings is so that you can attach the rubber dam outside the patient's mouth to the actual clamp. And what holds the rubber dam in place against the clamp are these wings. So what you're seeing here is a 12A winged clamp. You can see this is the buccal side, this is the lingual side. You can see the multiple beaks that the actual jaws of the clamp have. And then you can see the wings on the outside that are holding the rubber dam. Now, even though this clamp is designed to be able to do that, to be able to attach the rubber dam outside the patient's mouth, which I personally believe that it's clinically important. That's the way you want to do. You want to take your rubber dam and your clamp into the patient's mouth. I will share with you that even though I use only wingless clamps, like the ones that you're seeing here, this is a W3 clamp, this is a W2 clamp, and this is a W8A clamp. All these clamps have the same design. You can see the beaks, the active points, you can see the jaws and the bow, but they don't have any wings. So this will allow you to have more room for, again, your sectional matrices, your Toffel-Meyer bands, anything that you would need to use while you're doing operative dentistry. So many people would say, well, hey, yeah, but the downside of this clamp is that because it doesn't have any wings, you can't attach the rubber dam to the clamp. Well, I will share with you today a tip on how I use a wingless clamp and I still attach the rubber dam outside the patient's mouth, just like I would do with a wing clamp. And I'll share with you that tip later on my presentation. So the other thing that you want to make sure that you understand is that within the clamp options or clamp designs, you have what we call the passive clamp or the active clamp. And the word passive comes from, look at the location of the clamps beaks or jaws. They're parallel one to the other. So we can all understand that this clamp will have very little to no gingival impingement. So this clamp is going to be normally used on a tooth that has more of a clinical crown. But when you have these teeth that are now that require a lot of restorative work because they're broken down due to decay or fracture or attrition or abrasion or any other clinical reasons, you may have the need to use more of an active clamp. This is the W8A, W no wings, 88 is the design. And you can see that the jaws of this clamp are more angled. So this is more of an active clamp. And this clamp is going to require for you to be more careful when applying the clamp. Sometimes it will require for you to numb the patient's either lingual or palatal aspect so that they don't feel the pressure or the impingement of the clamp surrounding the tissue. Now, you want to try to avoid obviously engaging on the tissue. Now, can you always do that? You cannot, sometimes you can't avoid impinging on the tissue. So you want to try to do it. You try to achieve it the majority of the times, but there will be some cases where that's going to be a little more difficult and you're going to have to use some anesthesia. But again, that's why you have these two options. And again, like I said at the beginning of my presentation, our next presentation or part two, we're going to talk about modifying some of these clamps so that you avoid damaging the tissue. And those, for you to do that, these clamps will need some type of modification. And we'll show you how to do that as well. Now, the other way that you can classify the clamps is what we call, you can classify them by why they are used. And you can classify them calling them retentive clamps or retraction clamps. And again, these are two different words. Retentive clamp, this is a clamp that I'm going to use to keep my rubber dam in place. That's why it's called the retentive clamp. So this retentive clamp normally is going to go on my abutment tooth. And in this particular case, this retentive clamp is a W3. On the other hand, we have what we call the retraction clamp. And a retraction clamp, the name literally states it. This clamp is not meant to hold the rubber dam in place because that's what the retentive clamp does. The retraction clamp, what it should do is push the tissue and the rubber dam away from the operative field. So in some cases, you're going to find clinical situations where you're going to need two clamps. You're going to need a retentive clamp and you're going to need a retraction clamp in order for you to be able to work. And that's why it's important that you know all the different types of clamps that we have available for different clinical situations. Now, in this particular case, I'm using a W8A clamp. So it's a wingless clamp. You can see that is an active clamp. and I showed you that it has the jaws are more oriented towards the apical portion of the tooth. And this is a second molar. You can see that this second molar was very small on the lingual diameter. So that's why I chose to have that W88, because it's going to give me more pressure and it's going to give me more of a retentive feature. And don't forget that you're going to stretch the rubber dam around the bow. So if when you stretch the rubber dam on the dental bow, you're going to put pressure on the clamp. And if the clamp is not stable, this clamp will jump out of the patient's mouth. So you got to make sure that you select a clamp that gives you enough pressure on the abutment tooth to keep everything in place. So this is a W8A, and this is acting at right now is acting as a retentive clamp on this abutment tooth, that second maxillary second molar. On the other hand, what am I doing here? I'm going to bond a porcelain veneer. So I know that I need full isolation or full retraction of this rubber dam so that I can get access to the margin that I prepared for this veneer that I'm going to bond to this tooth number 9. So as you can see, I have a W2 clamp on one premolar. There's another W2 clamp hidden over here on the right-hand side of the photo on another premolar. So these two clamps are acting as my retraction, my retentive clamps, I'm sorry. They are retaining everything in place. But then you can see that because of the location of the gingival margins of these teeth and the lip of the patient, this rubber dam is pushed and is pushed down and is pushed incisively and is covering the gingival aspect of the neighboring teeth. Now, for this particular patient, I'm only going to bond a single veneer on this central incisor. So the only tooth that I need to retract the rubber dam is the actual tooth that I'm working on. So what am I using here? I'm using a B4 clamp, which is a retraction clamp to push the rubber dam and the tissue away and be able to access beautifully my my margin, my restorative margin, so that I can bond my restoration. So this is a good example of where you are combining a retentive clamp with a retraction clamp to be able to perform an operative procedure. Now, again, what I want to try to do is I want to try to simplify this to you. And I know that in the market, you probably find 30 to 35 approximately different type of clamp designs. And, if you think about it, I have never had more than these 4 clamps that you're seeing right here. These are what I call the universal clamps. Now, today, we're not going to talk about the 212 clamp. We are going to dedicate a full lecture. That's going to be our second webinar where we're going to talk more about the 212, the B4, and some other clamps. Right now, I want to concentrate is what I call my universal clamps. Now, my universal clamps are these 4 clamps, where we're going to concentrate today on the W3, the W2, and the W8A. And with these 4 clamps, I can tell you right now, you will be able to perform isolation in 99% of your cases in your practice with a combination of these 4 clamps that you have here. So that's the reason why I call them the universal clamps. And if you ask me, if you have to go out and buy clamps and have your office ready for all this, these are the 4 clamps that I would definitely have in my operative cassettes, because you're going to use them the great majority of times. So let's go into the clinical tech. We now know, what kind of clamps we need, what is it that we need to buy, and or what is it that we need to kind of bring out from our drawers before we do clinical dentistry. But let me walk you through now the clinical technique on how I want you to go about isolating teeth for any operative procedure. And the first thing that I'm going to go into is rubber dam perforations. And the reason why I like talking about rubber dam perforations is because when you have a rubber dam perforator, you see that the rubber dam perforator normally has between 5 and 6 different hole sizes. And you ask yourself, well, which one is the best, or which one do I choose for a particular case? And what I'm going to do for you is I'm going to try to simplify this as much as I can. Normally, the way that I do this is I only use the largest hole, and I use the largest hole for my retentive clamp. Now, that being said, I want to be very specific. Normally, my retentive clamp is going to be on a first or second molar. Because I'm going to use my retentive clamp on a molar, I'm always going to select the largest hole out of the perforator for that retentive clamp. If you decide that you want to use a premolar as your retentive clamp, meaning that you're not going to use a retentive clamp on a molar, then you're going to have to use the second to the smallest perforation, the one that you're seeing here, the one that I would use for every other tooth, because you're going to use a W2 clamp here. So the largest for the W3, the one right next to the smallest for the W2. If I'm going to use my retentive clamp on a molar, I'm going to use the largest hold. And for every other molar, for let's say that I'm using the second molar and I want to isolate the first molar as well, for that first molar, I'm going to use the hold that is right next to the largest. So I'm going to use the largest and the one right next to the largest for every molar, retentive clamp and the one that don't have any clamps. And for every other tooth in the mouth, I'm going to use the hold right next to the smallest. So these are the three holes or the three sizes that I use for every single clinical situation. And I have found that with those three holes, I can isolate without any problems any single tooth in the mouth. The other thing that I want to share with you is the distance between perforations. For our basic rubber dam isolation, basic, meaning that we're not retracting, we're not pushing we're not trying to go subgingival, we're just doing our basic rubber dam isolation, we have to use between 5 to 6 millimeters between each perforation. This is going to give you enough room for you to do a floss ligature if you have a deep margin, and I'll show you what I'm referring to. But this is going to give you enough room to push that rubber dam if you need to with a B4 clamp or with the floss ligature. And it's going to allow you to keep enough septum, enough rubber dam between each perforation so that you don't have any tissue displaying when you have completed your isolation technique. I'm going to repeat that again because I want to make this clear. Normally, some people have used more of a 3 millimeter distance between each perforation. And if you use such a small distance for every tooth, what's going to happen is that you're going to find that your rubber dam overstretches. And what that means is that you're going to see some tissue through the rubber dam, and that should not happen. So in order for you to avoid overstretching your rubber dam, you're better off having more distance between each perforation. And the distance that I have found that works in 99% of the cases is 5 to 6 millimeters for every tooth. So I don't even think about posterior or anterior teeth. I just do 5 to 6 millimeters between each tooth. I'm not worried if I get a little bit of a wrinkle between the tooth. I'd rather have a wrinkle that have tissue exposed. So again, what I want to try to do is make it very, very simple. And this is as simple as it can get. Now, when it comes to clamp selection, again, I always try to use my abutment tooth. I always try to select my abutment tooth to be a molar. So my retentive clamp, normally I want it to be a molar. And if that is the case, the only two clamps that I'm going to use is either a W3 or a W8A. If I were to choose a premolar as my retentive clamp, then I'm going to use the W2. But other than that, I'm always going to use either the W3 or the W8A. And again, it all depends on the amount of clinical crown that I have available and the size, the mesial distal width of the tooth. Because if the tooth is not that wide, like the case that I'm sharing with you right now, you see this is a second molar. And you can see that on the lingual aspect, the second molar is always narrower than on the buccal. So on the buccal aspect, the W8A, you can see that it fits the points of the beak are right on the gingival aspect or the cervical aspect of the tooth. On the lingual, I have one that is on the cervical aspect, but the mesial one is not. So it's more that the center of the beak that is holding this clamp in place. So again, what you want to have is you want to have four points of contact around the molar so that the clamp can be stabilized. And this is the reason why I use the W8A, because the W8A is narrower. The distance between the beaks are shorter than the W3. If I were to use a W3 clamp here, I would have all the beaks completely outside the molar, and basically I would not have enough pressure on the clamp on the tooth to stabilize all my rubber dam isolation. Again, keep that always in mind. Now, what is it that I call distant retention? Distant retention is when I'm using the clamp away from the tooth that I'm working on. And this is the ideal situation. This is what you normally want to do. You do not want to have a clamp on this tooth the day that you're delivering your crown. You want to have the clamp away from the tooth so that you have good visibility and good operative access to the tooth that you're trying to restore. So this is what I call distant retention. And this is the ideal situation. And this is the number one reason why I normally use as my retentive abutment tooth a the second molar, or the first molar if I'm going to work on a canine or a premolar. Now, this is another example of distant retention. You see, for this particular case, I'm going to be working on all teeth from canine to canine. I'm going to be closing the incisal embrasures using composite. So for me to be able to do that, I need to retract and I need to retain my rubber dam correctly, distal or distant to the operative field. In this particular case, I have chosen the first bicuspid on each side. So the first bicuspid on the right, the first bicuspid on the left, using a W2 clamp. And you can see that I've been able to isolate this area. And I'm just going to show you quickly. Now I'm working on the area. You see my floss ligatures are keeping the rubber dam out of place. This is the patient's lip, but you can see that I have full access for me to use mylar strips, for me to use a lingual matrix, for me to use any type of aid that I need in order for me to restore these teeth, because my clamps are further away. So that's why distant retention is ideal for operative dentistry or for any type of restorative procedure. Now, you can do what we call same tooth retention. That is something that you will find in the literature, and you will find in many journals, because it's something that is commonly used. The downside to it is, like in this example, if I have a clamp and I'm holding only on this tooth, when I stretch my rubber dam towards the bow, that's going to put pressure on the clamp. And because I only have one clamp and there's nothing else helping retain this rubber dam in place, this clamp may move or may jump out of the patient's mouth. So that's one of the downsides to same tooth retention. And that's the reason why when they, endodontists, when they're doing their endo procedures, they use these clamps like the 12A clamp, because it has multiple beaks. So they know that they can guarantee more of the clamp in contact with the cervical portion of the tooth, and giving or allowing the clamp less room for movement. So you can see here I've used a W8 clamp, a W2 clamp here, and another W8A clamp to do what we call the same tooth retention. I do this very rarely, but this is something that can be done if you want to seal an access for an endo, or if you want to post and you can get good stability with the W2 clamp. By all means, it is an option. Now, the other thing that I want you to know is another technique called the blind clamp technique. And this is a really good technique for operative dentistry, because what it does for you, that it allows you to use less perforations in your rubber dam. So what I'm doing right here, you can see that I'm isolating the cervical aspect of this premolar and this canine. And this is a dentiform, just to show you this clinical example. And I'll show you, another option to do the same thing, but why this is simpler, using this blind clamp retention technique. Because what you're seeing here is that I'm trying to restore the cervical aspects of this premolar and this canine. So what I've done is I've done 1, 2, 3, 4 perforations here, and I retain my rubber dam with the retentive clamp on the W3. I have 2 retraction clamps, 2B4s on these premolars, but I'm using a blind clamp. And what that means is that, you see, I have done no perforations on this side. I just perforated this canine because we were going to restore this canine as well. But you can see that I have avoided perforations here. And what that means is that you can achieve this type of isolation using your clamp on top of the rubber dam. And there is a clinical reason for this, because if you want to alleviate the tension of your rubber dam around these clamps that are retraction clamps, don't forget, these are not retentive clamps. These clamps can move, and they move easily because they're not as active as a regular clamp around the cervical aspect of the tooth. So if you were to do a procedure like this and you don't have another clamp on distant to the area that you're working on, all the tension that is going to be placed on the rubber dam while pulling the rubber dam out of the way so that you can attach it to the bow, what's going to happen now is that tension is going to move these clamps. So in order for you to alleviate the tension, you have to use a clamp on a distant tooth, or an opposite tooth, like contralateral first molar on this particular case, so that you can alleviate the tension. And the tension will be now, will be more towards these 2 very, very active clamps, because again, these have very sharp beaks, and they're going to be very stable around the cervical aspect of these teeth. Now, why is this easier? Why would I recommend you using a blind clamp technique? Because if you look at this particular case, and this is one of my cases, in order for me to achieve, I'm sorry, let me go back once. In order for me to achieve this type of, you can see that my rubber dam has no tension in here. Why? Because I have a W2 clamp over here and I have a W3 clamp on this side. So this clamp and this clamp are alleviating all the tension around my rubber dam in this area. If I were to just do a sectional or a portion of the mouth, just one quarter in isolation, all the tension of this rubber dam stretched over the patient's face through the dent to the face rubber dam bow will be set on this clamp. And if this clamp moves, this is the tooth that I'm working on. And you can see the tooth right here. You can see the clamp. This is a crown prep. And you can see the clamp going slightly underneath my margins. So if I put too much tension on this clamp is going to move and it's not going to allow me to bond or cement this gold restoration in place. So what I want to do is I want to alleviate the tension using this second clamp. Well, if I were to use a blind technique, I would not have, I don't have the need to do all these perforations. All I needed was to do one perforation here, a couple of perforations here, and then no perforation here, and add a blind clamp on this premolar. That is why the blind clamp technique is so helpful, because it's what's going to allow you to eliminate the tension without having the need to do multiple perforations and making sure that the perforations are at the right distance so that you don't have any tissue showing through your rubber dam isolation. So this is more complex to do than to use the blind clamp technique. So that's why I wanted to share with you that specific tip. So now that how to select the clamp and how to go about different different isolation techniques, I want to walk you through through a sequence of steps so that we go one step at a time, and we're going to go from perforating the rubber dam all the way down to full isolation and removal of the rubber dam. So our step number one, like I said, even though I use a W3, this is a W7 clamp. Even though I'm using this W7 clamp, and the W7 clamp, the only difference between the W7 and the W3 is the distance between the beaks. On the W3, they're a little bit closer. On the W7, they're a little bit further out. So this is what you would use for larger molars, mesial distally. So what I'm showing you right here is I perforate my rubber dam, and I'm going to wrap the rubber dam around the bow, around the dental clamp bow. So even though this clamp doesn't have any wings, so I don't have any wings to attach it to, I just attach it to the bow. And what that allows me to do is it allows me to use, and I'm going to show you a quick video here, it'll allow me to use any wingless clamp as a regular clamp, as a regular wing clamp, so that I can attach it. And I want you to watch the video. I'm attaching, you see, I use the bow of my clamp, and I'm just going to wrap my rubber dam around the bow. Now I'm going to align the jaws of the clamp with my perforations. And all I'm going to do now, you can see that there are the jaws of the clamp, and that's what I'm going to use to take both the rubber dam and the clamp into the patient's mouth. So this is a very simple technique, and it just allows you to attach your rubber dam outside the patient's mouth, which I think is important and easy to, it makes it easier for you to just take now the clamp, and that's your step two. You're going to now open the clamp jaws, separate them with your clamp forceps, and now you're going to make sure that the jaws of this clamp or the beaks of the clamp sit around the cervical aspect of the tooth. The beauty of this technique of placing the rubber dam and the clamp together outside the patient's mouth is that now all you have to do is just stretch this rubber dam on top of the jaws of the clamp and make sure that they fully seat underneath the clamp in the patient's mouth. And I'll show you that in step number three. So right now, step number two, you're attaching the jaws of the clamp around the cervical aspect of the tooth. And once you do that, in step number three, you stretch the rubber dam over the clamp. So this is what you're going to see clinically into the patient's mouth. You stretch that rubber dam, and you make sure that the rubber dam goes underneath the jaws of your clamp. Now, sometimes I do want to make this very clear. Sometimes when you do this, you'll notice that the clamp will go underneath the jaws, and you still have a little bit of tissue or saliva coming through this area, these little corners right here where my arrow is pointing. So what I do to avoid that leakage is all you have to do is grab your clamp forces, put them back on the clamp, just open the clamp a little bit and allow the rubber dam to sit around the cervical aspect of the tooth, and then let go of the clamp. And that will take care of that very easily and very quickly. So let me show you a quick video here. And I want to show you now how we're going to attach. You see, I'm attaching the clamps to the forceps, And now I'm going to take it directly into the patient's mouth. So you can see that the rubber dam is held by the clamp, by the bow of the clamp. And now that I've seated, that I fully seated the clamp on my abutment tooth, what I'm going to do now is I'm going to stretch. You see, I'm stretching the rubber dam so that the rubber dam can sit underneath the jaws of my clamp, underneath the beaks of those clamps. And again, if you have any leakage or if you have any tissue showing, all you need to do is open the jaws of your clamp, and that would allow the rubber dam to sit around the cervical aspect of the tooth and seal the tooth perfectly. Step number 4 will be, now you have to make sure that all the other perforations, you stretch the rubber dam over each tooth to be isolated. And sometimes you're going to need a floss to help you do that. So I initially try to do that with my hands, just kind of floss the rubber dam through the contact areas. But sometimes you have contacts that are very broad and very tight, and you're going to need the help of a rubber dam. So this is for sure something that needs to be done with a four-handed dentistry technique. You have your assistant; she can floss for you while you're holding the rubber dam in place. Make sure that and I'll show you a video at the end, when you floss through the teeth, make sure that you don't bring the floss up the contact area to remove it out of the patient's mouth. Just pull the floss towards the buccal so that it comes out through the embrasure areas, and that way you don't bring the rubber dam back coronally. You want to try to avoid that. Step number 5 is to invert the rubber dam. In this particular case, I'm going to bond an indirect restoration on this preparation. And in order for me to do that, I got to make sure that my rubber dam inverts correctly subgingivally. So it goes subgingivally so that it can hold all the clavicular fluid underneath my gingival margin, or underneath the margins of my preparation. Now, in many cases, you will find that if your perforations, and you can see that my perforations are 5 to 6 millimeters apart, and the reason why I do that, again, is because I don't want any tissue showing. And you can see throughout this isolation, there is no tissue showing. I'd rather have a little bit of a wrinkle here than having tissue showing and saliva leaking through my rubber dam. So because I have nice separation between my perforations and the size of my perforations are correct, again, for this tooth, I use the second to the largest perforation. And for this tooth, I use the largest perforation. And for these two teeth, I use the second to the smallest perforation. You can see how easily my rubber dam inverts underneath the gingival margin without me having the need to use any other aid, a clamp or any type of ligature around this tooth. This is the actual rubber dam inverting subgingivally without any problems because of the technique that we have followed. Now, you will find some cases where that is not possible, where you will find very deep margins where your rubber dam is not going to, it's not easily going to be inverted. And I'll show you what you need to do in those cases. And this brings me to my step number 6, which is what I call the floss ligature technique for posterior teeth. Now, this floss ligature technique, and this is what you're seeing here, both of these teeth, this tooth has a root canal, and I'm going to remove this temporary here so that I can prep this tooth and restore it. And it has a very, very deep margin. And I'll show you the x-ray for this tooth so that you can see how deep that margin was. But I still want to have full isolation. I want to have control of the operative field. In this particular case, you can see, look at the mesial and distal margins, very deep. What you're seeing right here, this tension of my rubber dam is caused by the tissue. So this is tissue here, and this is tissue here. So this is the rubber dam and my floss ligature pushing that rubber dam underneath the gingival margin. Without a floss ligature, I would not have been able to expose the margins, mesial and distal margins of this preparation. So this is why using the floss ligature technique, in my mind, is very, very important, because in many clinical situations, you will only need to use a floss ligature and one retentive clamp to do your full isolation. You're not going to need the aid of additional clamps. Now, there will be some cases where the floss ligature won't work either, but those are, they're not the majority. The majority of cases, you're going to be able to retract or push that rubber dam subgingivally using a floss ligature. Now, how do you do the floss ligature technique? And you can see that I just got a floss without any wax. I folded the floss in half, and all I'm going to do is just tie a knot closer to the closed end of my floss. So the open ends of the floss are going to be on the right hands on the left hand side and the close end on the right hand side. And you can see that my knot is closer to the close end. So this loop is now what I'm going to use to go mesial and distal around the tooth. And again, you're seeing here, here's the knot. The loop is on this side. Both ends are on down here. You can see that I have placed one side of the loop to the mesial of the tooth, one side towards the, to the distal of the tooth, the other side towards the mesial of the tooth. And all you have to do there is grab both ends, both loose ends or open ends of the floss, and make sure that you approximate the knot towards the gingival aspect of, or the cervical aspect of the tooth, until you find that the knot is very, very tight around the cervical aspect. Now, in this particular dentiform, I don't have a rubber dam, and I don't have the rubber dam for a reason, because I want you to see how this floss goes, pushes itself when you tighten the knot, it pushes itself underneath the gingival margin. And what this floss is going to do when the rubber dam is in place is going to push the rubber dam subgingivally so that you can go underneath the gingival margin in those deep margin cases. And again, I'm going to share with you some cases. This is a case that I shared with you at the beginning, where the patient had a root canal. She had a retreatment done on this tooth. When the endodontist completed his retreatment, I had restored the tooth initially with a resin modified glass ionomer so that he was able to isolate. And then he sent back the patient with this temporary filling here. I removed the filling and removed all my glass ionomer preparation. You can see I have sealed now the pulp chamber. Look at the margin. This is all dentin. And I want you to look at the rubber dam. You see, this is tissue right here. And the tissue is beyond the gingival margin of my preparation. So the only way that I was able to get this rubber dam out of my way is through this floss ligature. And what this is going to allow me is that it's going to allow me now to place a Toffel-Meyer band and be able to restore, elevate that gingival margin. This is what I did specifically for this particular case. I elevated that margin, and you can see here now with my margin elevation, and this is bonded to the actual margin of the tooth, and I'll show you the x-ray. But all this was done under rubber dam isolation. Because if you think about it, if I did not have a rubber dam isolation and I place a Toffel-Meyer band to elevate this margin, I just want you to think about the bleeding of the tissue, the curricular fluid, all that getting into that area that I'm going to bond to. And that contamination is going to avoid my restoration or my margin elevation to be predictable. So I just want to show you the x-rays of the case, and you can see here, this is the failing root canal that the patient had, and you can see it right here, failing on the mesial roots. So we send this patient back to the endodontist. He removed the fiber post that the patient had inside. But I want you to look at the margin. The tissue level is over here. And look at the restorative margin. So this is 2 to 3 millimeters underneath the gingival margin. And this particular patient, for medical reasons, could not have clinical crown lengthening procedure performed. So you're seeing here, this is the bone. So I do have good biological width. The tissue was around this area. And you can see that there was an open margin the entire time of this previous restoration. So what I did is I elevated the margin so that I have now a new restorative margin that I can use to restore this with an indirect restoration. But in order for me to achieve this margin elevation and to be predictable with my margin elevation, I needed to isolate this margin. And the only way that this margin was going to be able to be isolated with a rubber dam is by using a floss ligature technique, because that was the only way I was going to be able to push that rubber dam subgingivally and have good access to a clean margin in that distal area of the tooth. Now, my step number 7 is to show you when you do not need a floss ligature. So in this particular case, you can see, yeah, my rubber dam is a little bit wrinkled up here, and you can see that it's covering the cervical aspect of the tooth. But what am I doing for this patient? This patient had these white spots here that she disliked, and I was going to do resin infiltration on to eliminate those white spots. So literally, my operative field was the incisal third of both 8 and 9. So why would I need to place a floss ligature on the cervical aspect of these teeth to push this rubber dam apically? There is no need for me to do that. So if there is no need, I don't mind if the rubber dam is wrinkled. I don't mind if the rubber dam is, covering an aspect of the enamel, because there's nothing I need to do up here. All I'm going to do is going to be on this incisal on both incisal thirds of 8 and 9. So again, there's a clinical reason why you would use a floss ligature, and you don't need it for every single case. But let's look at this other case. See, this is a different clinical situation. I need to restore these preparations here. And you can see that these preparations, if it was not for the floss ligature technique, this rubber dam will be impinging on these margins. So please keep that in mind. The floss ligature technique today is more important than ever because it's going to allow you to push that rubber dam apically and give you a more myriad or variety of clinical cases that you're going to be able to perform on the rubber dam. And today we need to do that. We need to do that because we need to protect ourselves, we need to protect the people that we work with, and we need to protect our patients. So by means of using a rubber dam, I can reduce the amount of aerosolized particles with my suction and the rubber dam. But at the same time, if I'm going to be able, if I want to use this clinically, I have to use the right technique. I have to use the right aids in order for me to achieve this type of isolation. Now, the other aspect that I want you to share with you in step number 8, and it's a very important aspect, is that you need to secure your rubber dam. So once you place your retentive clamp and you have your operative field ready to work, you can see that I went from this tooth to this tooth. Now, I'm not worried about the rubber dam being around this tooth because I've already built up my core and everything under rubber dam isolation. I remove my Toffelmeyer and I'm going to the next tooth now and I'm going to restore this tooth. But in order for me to be able to move this and to keep everything in place, I need to secure my rubber dam. So this is when I use my wedges. And these wedges, they're very easy to just remove, just to cut a portion of this. They don't need to be that long. But the nice thing about them is that they're thick enough. They're going to go into the contact area and underneath to the gingival margin or to the gingival embrasure and stay there so that they can secure your rubber dam. And what this is going to do is that it's going to avoid either your patient slip or you working around the area, pushing that rubber dam coronally and displacing the rubber dam, which is something that you don't want to do and you don't want to happen while you're working on your patients. So as in a summary, I'm going to share with you this video here because I want to summarize every single step and make it clinically applicable for you. So I'm going to just summarize all these little steps that we've made and I'm going to share with you how you go about them in a dentiform, just to make them nice and clear. The first thing that I want you to do, don't forget, set your perforations. They need to be 5 to 6 millimeters apart. The perforation for the tooth where you're going to place your clamp, if it's going to be a molar and you're going to use a W3 or the W8A, you want to use the largest hole in the perforator. If you're going to use a premolar as your abutment tooth for your retentive clamp, you're going to use a W2 and you're going to use the perforation right next to the smallest. So there's only 3 perforations that you need for every tooth in the patient's mouth, and these perforations need to be approximately 5 to 6 millimeters apart. The second thing that I want to remind you is how you attach the rubber dam around the bow of the clamp when you're using wingless clamps like the ones that I recommend for operative or restorative dentistry. Again, these clamps allow you for more room, for more operative field room. You have more space for your Toffelmeyer bands, for your sectional matrices, for your wedges, for all the things that we normally use when we're performing restorative dentistry or dental procedures. Once you do that, you're going to open the jaws of your clamp using the clamp forceps. And you see, you're going to take your rubber dam and the clamp at the same time within the patient's mouth. You can see that you open the jaws and you secure this W3 clamp around the cervical aspect of that molar, the molar that you choose. We chose here this second molar. And once you do that, all we have to do now is stretch the rubber dam around the jaws of the clamp. And again, if for whatever reason you feel that there's some tissue or some tooth structure showing and you're going to get some leakage around that area, all you need to do is grab the forceps, just open the jaws of your W3, allow the clamp to sit fully around the cervical aspect of the tooth, and let go of the clamp again, and that will guarantee that you don't have any leakage. When you're putting the rubber dam through the septum, you always want to use a floss. You want to make sure that the floss is going to help you push this rubber dam subgingivally so that it gets correctly inverted in the interproximal areas. If you have any deep margins, if you have any deep preparations, and you want to use a simple aid to push that rubber dam apically, the best way to do it is using the floss ligature technique. And you can see how we're developing the knot right here. This knot should be closer to the close end of the floss than to the open ends of the floss. And I just want to show you here, distal to the molar, mesial to the molar. If this is the tooth that you want to push that rubber dam away, you're going to put it mesial distally, and now you're going to close the knot towards the cervical portion of the tooth. And you can see that I'm just closing, I'm just pulling the ends of the floss and making sure that this knot is nice and tight around the cervical area of the tooth. While you're tightening that knot, you will see that the rubber dam is being pushed apically or subgingivally around the tooth. And this is very useful for those for those difficult cases where you have deep margins and that you need to restore, for whatever clinical reason. Now, once you have placed your rubber dam, step number 9 would be removal of the rubber dam. And again, this is a easy thing to do. All you want to do is just overstretch the rubber dam so that you can, separate the rubber dam from the actual tooth and have some tissue visible. So now you're going to see the septum of the rubber dam, the septum between each of the perforations. And what you're going to do is you're just going to cut through the septum, and that's going to give you a very nice and open hole. Very easy for you to just go ahead and remove the clamp and then remove the rubber dam completely out of the patient's mouth. Now in step number 10, and with these, I'm going to share with you a couple of more photos, and we're getting now towards the end of our presentation, so make sure that you have your questions so that we can review them towards the end of the presentation. But I just want to share with you a couple of tips that may become useful. We're going to share more advanced procedures on our part 2 of this webinar, but just a couple of tips that you may find useful for this particular case. This is what we call a split rubber dam technique, and this is something that you can do. And again, it's just you do some multiple perforations, you cut through the rubber dam, and we're going to show you a little bit more about this in part 2. But just to show you a split rubber dam technique, if you want to bond some veneers. Now today I rather use a closed rubber dam technique, but if you haven't used a rubber dam in a while and you're just trying to get back to making sure that you can you get used to handling the rubber dam again, some cases are going to be a little bit more challenging for you to isolate. So techniques like the split rubber dam technique are still a valid technique. Now, one recommendation that I would give you in today's world is that if you're going to use a split rubber dam technique, I would use a nice resin barrier, like this blue blockout resin that I have used, and I apply it around the rubber dam so that the rubber dam not only stays in place, but I'm sealing the rubber dam. This liquid dam or this blockout resin is light cured, and it cures fairly quickly. So what I did here is that I did a split rubber dam technique. I have 2 W2 clamps creating that retention and alleviating the tension in this area. But at the same time, I applied a little bit of this blockout resin, as you can see here, just to secure my dam in place and to seal everything around it. So this is going to seal that area that you've opened when you split your rubber dam with a scissor. You seal that area and you secure the rubber dam in place. So this is one good tip if you decide to use a split rubber dam technique instead of using a closed rubber dam technique and more of different design clamps. Again, there's just clinical options, just to keep that in mind. Another thing that I want to share with you, another tip, is that another important tip that I feel that is clinically relevant and very important is that when you have these back-to-back class 2 restorations, if you select the right tooth, if you, like in this particular case, we chose the abutment tooth to be the second molar and not the first molar, we have more room in order for us to place our sectional matrices, to use our metal bows to keep the, to put the tension around these sectional matrices, and to place our wedge so that we're able now to restore these proximal surfaces at the same time. So again, having that distant retention is always ideal and good for operative dentistry. The other thing that I want to share with you is using these auto matrix bands. I think that they're very useful for operative dentistry because you have less things, less items to worry about. You don't have your Toffel-Meyer band holder. All you have here is a you have a retainerless band around this tooth, and this is the auto matrix system with a wedge. And you see again, I'm using distant retention, and you can see here that I opened the jaws of my clamp to allow the rubber dam to fully sit around the cervical aspect of the molar, but I'm distant to the tooth that I'm working on. And this is, every time that you can do that, that is always the ideal situation. Now, when you can't do that, like in this particular case, you can see that I have my clamp around the same tooth that I'm working on. But because I chose these retainerless bands, or this auto matrix band system, I don't have a lot to worry about. I don't have a lot of things in the patient's mouth that this clamp would interfere with fully seating. So when you have cases like this, there are some dental materials out there like these bands that we can use, and they become very, very useful for cases where you need to place your clamp on the same tooth that you're going to restore. And I want you to see, this is a very large restoration that we're performing on that tooth.